World Health Partners.
For larger states, even up to 8 to 10 microsites. So there would be one microsite in a city, and larger states have 8 to 10 prominent cities where large number of footfall of patients in a concentrated ecosystem of hospital, laboratories, and pharmacies. This ecosystem is what we call a microsite. So we feel, and in smaller states, it could be say 4 or 5, and still smaller, it could be just 1 or 2. So that is how we envision the microsites to be. We already have one microsite running in Mumbai in a PATH project, and where in 7 wards of Mumbai, this ecosystem has been digitized, has been enabled on ABDM, and the ecosystem is giving the experience of the digital health to patients. Now, after the PATH project, we have come up with 2 more microsites in Ahmedabad and Surat, which are presently being implemented. And now, after this Ahmedabad, Surat, we have now thought that all over the country there should be a microsite implementation. And within this microsite implementation, because all 100 are not going to come up suddenly, and all are not going to start together, we also felt that we could ride on this tuberculosis program. As you are implementing the program, we thought that since you are already engaging with the state level machinery, also you have foot soldiers on the ground. So we thought we could engage with you, and we are presently in the process of framing guidelines. We also thought that before we frame guidelines, we should get inputs from the people who are actually implementing and who are maybe going to implement the microsites. So that is the context in which we are all here. And Akshay and I think Vikram, they've already had one session with maybe all of you or some of you. But I think this is an opportunity for us to understand your concerns and how do you see this rollout of microsites happening in the states. So I think we'll start with a small presentation which Akshay has prepared. So Akshay, you can start with the presentation. Right.
Hello, everyone. Good afternoon again. Next, please. So as most of you would be knowing, the vision of the Ayushman Bharat Digital Mission, that we want to create a digital health, national digital health ecosystem. So where we support the universal health coverage by making the data interoperable and by leveraging the standard-based digital systems, so that the security and privacy, confidentiality of the patient data is also secured at all points of travel of the data. So it is based on some of the principles. Some of the principles are technology-based. Some of the principles are policy-based. Some important one of them is federated data architecture, that the data remains where the data is created, and therefore data is not stored at a single location. We have some repositories which we are maintaining as single source of truth, where we want to give uniquely identify all the stakeholders of the digital health ecosystem. Like every person would be having Aadhaar number, every health facility would be having health facility registry number, every health professional would be having health professional ID. Then we have on the policy side, the Ayushman Bharat Digital Mission is a voluntary participation, and it is completely wellness centric, and privacy and security of the data has been taken care of right from the start in the design of the Ayushman Bharat Digital Mission. Next, please. On a very high level, Ayushman Bharat Digital Mission, what does it do? You can see that various private hospitals, government hospitals, or government programs, or laboratories, or various frontline workers, they all are maintaining or creating health data. Many of them are creating it digitally also, but they are not connected to each another. So what we want to do is we want to develop an Ayushman Bharat Digital Mission highway, where they connect to the Ayushman Bharat Digital Mission, and they can get connected to themselves also. So the data which they create becomes interoperable to be consumed and taken care of, can be used by other healthcare providers also. Next, please. While integrating with different stakeholders, we have integrated with government health programs. Many of them are listed here. Major ones are Coven, NCD, NVHCP, RCH, Nikshay. We are integrating with government health solutions also, like eSanjeevani, eHospital, eSushrut. State government programs are also integrated with us, some of them. We are integrating with the health solutions of the private players like EkaCare, Karkinos, Briefcase, Paytm, or Pacto, SRL Diagnostic, Narayan Health, etc. So we have integrated around 100, more than 100 players on this fragmented ecosystem that we have in India. And 700 of them are still ongoing or integrating with us on our sandbox. Next, please. So this is the statistics that we have. We have around 38.5 Abhas created, which is created for every Indian that we have. But we have population of 144. We have created 2.1 lakh health facility registries and 1.8 lakh health professional registered on our health HFR and HPR. But we have more than 20 lakh facilities and 50 lakh health professionals in India, estimatedly. We have around 600 crore health or I'll say the interaction which people do with the hospital healthcare facilities in every year, 600 crores. And we have around 626 crores Ayushman Bharat or the ABHA linked records that we have now. So there is huge potential that we need to still cater to. Next, please. What are the challenges we are seeing while making or increasing the adoption of Ayushman Bharat Digital Mission are the limited awareness that we have in the healthcare ecosystem. This ecosystem or every player in the ecosystem has limited awareness about it. Major strides are done in the government sector, but private sector is yet to pick up. We see health professionals has a very they face a very resistance in changing their habits. So behavioral changes involved. They want to change the habits from physical to digital. They need to create the digital health records. Then fragmented distribution of ABDM enabled provide. Even we have enabled some of them, but they are also fragmented. So people or the general public is not able to see the complete ecosystem or the benefit coming out of healthcare services being delivered digitally to them. So, and obviously patients also have limited knowledge about limited knowledge of ABHA and its benefit. Next, please. So for this, we tried to initiate with the help of NGOs, microsites. Microsite would be a limited area, limited geography, as sir was also mentioning about it, that limited geography where all the stakeholders would be asked to use digital or ABDM enabled solutions, and then they create digital health data so that patient can also see the complete flow of digital health delivery. So they get digital prescription, which they can use with their subsequent encounters, which they can use for themselves, for sharing with the pharmacy, etc. So this kind of microsite that we want to develop in a limited geography. And as you can also understand that this, if you do it, it is going to tackle many of the challenges that we saw in the earlier slide. It is going to it can be dedicated to the private sector. It can increase awareness to the patient. It can increase awareness to the ecosystem players. It can increase the geographical spread of the Ayushman Bharat Digital Mission in India, etc. Next, please. So we did 1 or 2 microsites. One was in Mumbai, in 7 wards in Mumbai with the help of PATH. We did in 7 wards in Mumbai, and the lower arrow shows the achievement that we are doing in this microsite. In this microsite, PATH has approached around 3,800 doctors. 972 of them registered on HPR and 865 registered their facilities on HFR, and 810 of them accepted or adopted the Ayushman Bharat Digital Mission enabled health information management systems. And then they created more than 12,000 ABHA linked records. So many of them don't want to go back to the analogous way of handling their patients now. Next, please. Another site which has just started in month of March 2023 is in Surat and in Ahmedabad, where it is said to be where we are going to approach 600 doctors in Surat and 800 doctors in Ahmedabad. And where currently also there 393 doctors have been approached and 275 have registered on HPR and 33 have registered on HFR, and 7 plus have adopted HMISS system. So it is just the results are just starting. Next, please. So by the successful learnings from those two microsite, we thought that if we establish a goal that we are going to establish 100 new microsites in complete all over the country in different states, 2 3 states. Every state would be having at least 2 3, and big states can have much more than that. And for this, it was approved by the mission steering group of ABDM, and it is chaired by Honorable HFM, Health and Family Welfare Minister. And budget outlay was earmarked for it for of 30 crores. And in this, fund disbursal would be done to the states based on the milestones. That is also, we are in the process of making up the milestones, on what objective milestones we can disburse the fund to the implementing agencies also. Next, please. So this is the implementation path of the project. That first we need to identify the sites and the partners who are going to implement, and the sites where it is going to be implemented. It can be as per the defined criteria and the policies. We have done some work over it, that how many sites or which sites we can zero down to. Addressing concerns of feasibility, connectivity, and adequate provider presence also has to be there. And we need to see what strengths that you have or in those sites, and what capacities that you have there. And then regional priorities also are to be catered to in this. Then we need to plan and implement the project. That we need to plan, we need to do a mapping exercise, how many private providers are there in that area, and then how many are going to be sensitized and onboarded for HFR, HPR, etc. Then we implement the project. Then monitoring supervision is going to come after it, and then we have outcome based payment. So the payment has to be based on objective and unambiguous performance data indicators. Next, please. Role of the partners in this microsite would be, they are going to lift the heavyweight in this hiring of the human resources that they need to do. They need to build their capacity. Then they need to do a mapping exercise to understand the complete universe, that how many people they are going to approach in this. Then they need to prepare a strategic plan for it, and implement the project as per the policies and guidelines. Then maintain regular coordination with the state teams, and then receive the payment based on the outcomes. So more or less the outcome would be related to how many HPRs are getting created in that microsite, how many HFRs are getting created, how many facilities have started using ABDM enabled HMIS system, and how many health record, Aadhaar linked health records that they are creating. Next, please. Financial model, tentative financial model for this would be, timing of the microsite would be around 6 to 12 months, because 1 or 2 months are generally are the incubation period where team approaches the doctors, then they change their behaviors, they adopt the system, they learn the system, then they start using the system. So as was seen in the Surat and Ahmedabad microsite also, that we started the microsite in the end of March, but still in the month of May we are seeing that not good results are out of it. We are only 8 plus or 7 8 people have started using HMIS, but 1 or 2 months are generally lost in the incubation time. So timing of the microsite would be flexible around 6 to 12 months. And budget, I've already mentioned, it is 30 crores and 100 microsite we are planning, so it will be around 30 lakh rupees per microsite. Multiple milestones are being defined currently, that we need to make the payments based on the milestones that we are currently defining those milestones. And the criteria is mostly, the milestones would be around these objective criteria of HFR, HPR, and HMISS players, and how many health records are getting generated. So as you can see that it is expected that 20 to 25% conversion generally happens in a microsite universe. So if you are approaching 6,000 people, then around 10 to 25% of people are going to convert, and accordingly the payment would be received by the implementing agencies. With the higher conversion rate, obviously would be able to achieve the milestones early, and would be able to get implementing agency would be able to get the payment early. Next, please. So, sir, now in the presentation, what we have done, that we have divided the presentation now as per the partner base. So we can start with the partners also, and then they can let me just go to the last slide to understand the discussion point for the meeting. Then we can come back to this slide and ask the partner wise to give their inputs on those discussion points. Right. Nikar, can you please take us to the last slide, the discussion point slide? So these are the points of discussion that we'll be asking everybody present in this room to give their feedback and their input to. What do you think about the funding mechanism? How dispersal of funds from NHA to states or implementing nation? What are your inputs about it? What do you think about the engagement model, and what kind of model should we adopt to? What kind of engagement are you already having with the state? Are you running any program in the state in any of the districts? And are there any geographic preferences that you or your entity has? And bank guarantee, because we are also thinking of providing mobilization advance, because some amount of money has to be provided beforehand to the implementing agency so that they can hire people.
That is also open to discussion.
Yes.
See, in case you feel that some amount of seed money or mobilization advance is needed, then of course, as a government body, will need the bank guarantee. If you feel that your organization is strong enough to sustain for the initial 2.5 months, because that is the time it will take to actually start reaching some numbers, then if you can sustain yourself, then I think no advance would be given and no bank guarantee as such would be needed. So we can have a discussion around this.
Yes. So we can discuss about it, that what are your inputs about the bank guarantees and the funding mechanism, etc. So Nikar, can we just go back to the partners profile one side, this side? Thank you. So sir, now we can ask.
Yeah, we'll request doctors for you. I think you can go ahead and tell us about your presence in the geographies. How do you see this project? And please give us your inputs.
Good afternoon, ladies and gentlemen.
You people can also have a small round of introduction also before you give your inputs.
Thank you so much. I'm Tipti and I'm from Doctors for You. So first of all, good afternoon. Hello. Yeah. Thank you so much, everyone. Thank you for this opportunity. And I'm Tipti from Doctors for You. So basically, I would like to thank you or everyone present here. So first of all, I would like to know that Doctors for You is a 15 years old NGO, and we are working in 25 states and 3 union territories of India. Apart from India, we are also working in Nepal and other nearby countries. So right now, obviously, we are working for this PPSA program for tuberculosis patient. So we are working in 4 states. Okay, sorry. I'm a little nervous. So we are working in 5 states right now, and it's really great to be a part of NHA team. And thank you so much.
We would like to listen about your geographical presence, not only state, maybe within the state, district, or large cities, where because microsite would actually involve. Imagine in Delhi, it would mean, say, AIIMS and Safdarjung, that area, which has 2 big hospitals, and then has a lot of labs, a lot of pharmacies, maybe other health specialists sitting there. So that ecosystem is a place where collectively you would have a footfall, not just in AIIMS, but the overall ecosystem, a large footfall. So that is what we call a microsite. Maybe with your presence in these states, if you could tell us, which would be the immediate cities which come to your mind where such a microsite is feasible. Then, of course, the discussion around how to actually some inputs regarding the guidelines, whether you feel that you can start it off, what kind of capacity building you would require. Of course, we will undertake the capacity building, but you would, how much time for capacity building, how much time for mobilizing the team, all those activities, if you can also tell us about.
So Doctors for You is specialized for disaster response. Right now, if I can talk about Manipur, so yes, our Doctors for You team is there for the quick response. So we are known for. So apart from that, Doctors for You, if you talk about which state we are working on very quick response, so whether it is required. But apart from that, obviously we have a very good presence in Bihar, UP, MP, Rajasthan, Maharashtra. Maharashtra is our registered office. So basically, yeah. Apart from that, Delhi.
So you're already running the TB program in Assam, Maharashtra, UP, Bihar, and West Bengal.
Yes.
Okay. So within these 5 states, what would be the cities that you would really feel that microsites would be doable and would be desirable and you can maybe take it forward?
So
Hi, I am Dr. Shubham Negi from Doctors for You. So, whatever I have understood, we have to make a microsite so that we can make people, aware about this scheme, this Ayushman Bharat, and can help them in enrollment. So, if I talk about these 5 states, I guess UP will be best also for us. Okay, and other than that, we are all our help desks like also working in Safdarjung Hospital. So there also we are very comfortable. If anything we can start because we already working over there, and in Safdarjung as well as in Loknayak Hospital also our project is going on, LNJP Hospital. And so yeah, if it is Delhi, so we can start with microsite as like pilot in the Safdarjung too. Other than that, UP will be best, Maharashtra will be best.
You have
So-
any specific city in
No, what we'll do is maybe I think थोड़ा शायद हम ही में कमी है, हम आपको थोड़ा और इसका डिटेल बताते हैं
Yes.
माइक्रोसाइट में एक्टिविटी क्या होगा. आप ट्राई टू इमेजिन कि अगर आज आप उस एरिया में जा रहे हो तो वहां पे एम्स में तो अपना सॉफ्टवेयर लगा है, HMIS लगा है, वहां से एक प्रिस्क्रिप्शन जनरेट हुआ. अब वो प्रिस्क्रिप्शन लेकर एम्स के बाहर पेशेंट आया, सामने वो बड़ी बड़ी दुकानें हैं वो फार्मेसी वाली, अब वो प्रिस्क्रिप्शन लेके वहां मेडिसिन लेता है, मेडिसिन फिजिकली कागज दिखाता है, दवाई मिलती है, पैसे देता है. ऐसे ही अगर कोई लैब टेस्ट कराना तो कहीं थोड़ा दूर जाके किसी CT स्कैन सेंटर पे जाएगा, वहां लैब टेस्ट करवाने चला जाएगा, वहां भी ये सारा ट्रांजैक्शन फिजिकल मोड में हो रहा है. हम ये चाहते हैं कि ये जो इकोसिस्टम है इसमें ये जो ट्रांजैक्शन फिजिकल मोड वाला है, जब वो अस्पताल से बाहर आके कहीं दूसरी जगह पे जा रहा है जहां उसको सर्विस लेना है, तो वो वाला ट्रांजैक्शन भी डिजिटल हो. इसके लिए जरूरी ये होगा कि उस लैब में या उस फार्मेसी में जो HMIS जो भी सॉफ्टवेयर लगा है वो ABDM एनेबल्ड हो. तो वो बात आ रही है, और जहां वहां कोई छोटा डॉक्टर बैठा है, कोई प्राइवेट डॉक्टर्स बैठे हैं, उनके पास जो सॉफ्टवेयर है वो HMIS जो है वो ABDM एनेबल्ड हो. ये तो एक कार्य होगा. दूसरा कार्य होगा, उस एरिया में समझ लीजिए 500 डॉक्टर बैठे हैं, 1000 लेबोरेटरी है, जो भी ये लोग हैं उनके यूनिक आइडेंटिफायर क्रिएट करना होगा. उसका डॉक्टर का और नर्स का यूनिक आइडेंटिफायर, या जो और कोई हेल्थ प्रोवाइडर है उसका यूनिक आइडेंटिफायर है HPR, हेल्थ केयर प्रोफेशनल रजिस्ट्री. और जो जिस जगह पे वो बैठा है, चाहे वो अस्पताल है चाहे लेबोरेटरी है, उसका यूनिक आइडेंटिफायर का नाम है HFR, हेल्थ केयर फैसिलिटी रजिस्ट्री. तो अब उसका यूनिक, अब आप समझिए जब आप किसी नए क्षेत्र में जाएंगे, वहां पे आपको पहली कार्रवाई ये करनी पड़ेगी, जिसको हम कह रहे हैं लॉन्च करने के टाइम, आपका जो भी आपने स्टाफ रखा हुआ है उस स्टाफ को दर दर पे भेजना पड़ेगा. जब आप उसको दर दर पे भेजोगे, वो वहां जाके उसको कन्विंस करेगा डॉक्टर को कि भैया आप अपना HPR बनाओ. वो नर्स को कन्विंस करेगा कि आप अपना HPR बनाइए. फिर उस डॉक्टर को बोलेगा कि आप अपने क्लिनिक का HFR बनाओ, और हो सकता है उसको बैठ बैठ के बनवाना पड़े. राइट. तो ये एक्टिविटी में समय लगेगा. फिर वो उसको बोलेगा कि अब आपका HPR HFR बन गया, अब आप इस फैसिलिटी पे HMIS क्या यूज करते हो. तो HMIS यूज करवाने के लिए भी उसको कन्विंस करना पड़ेगा. इसमें आपको सहयोग मिल सकता है, कोई प्राइवेट HMIS वाले भी घूम रहे हैं, उन्हीं को पकड़ लो कि भैया तुम कन्विंस करो, क्योंकि आफ्टर उसने अपना प्रोडक्ट सेल करना है. तो प्राइवेट HMIS वाला भी आ जाएगा अपने आप, अपना वो भी आके बोलेगा कि डॉक्टर साहब मेरा ले लीजिए, HMIS ले लीजिए. राइट. तो ये एक्टिविटी जब हो जाएगी, इसके बाद एक्टिविटी शुरू होगी हेल्थ रिकॉर्ड लिंकेज. इसके बाद जो भी पेशेंट वहां जाएगा, वो पेशेंट का जो हेल्थ रिकॉर्ड है उसका आभा बनेगा वहां, क्योंकि वो HMIS जो है वहां अब वो आभा बना सकेगा. आभा बनते ही उसका रिकॉर्ड लिंकेज शुरू होगा. तो ये एक्टिविटी जो पहले आपको हो सकता है महीना, 1.5 महीना, 2 महीने एक एक्टिविटी करनी पड़ेगी, जिसके बाद आपको हेल्थ रिकॉर्ड लिंकेज ऊपर आना दिखना शुरू हो जाएगा. सो दैट इज द एक्सरसाइज. अब इसमें मैं जो जानना चाह रहा था आपसे वो ये है कि क्या यूपी में जैसे बड़े शहर हमने जो आइडेंटिफाई किए, मुझे करेक्ट करिए अगर गलत है तो, आप यूपी में सोच लीजिए वाराणसी है, कानपुर, लखनऊ, मुरादाबाद, नोएडा, ग्रेटर नोएडा, ठीक है, मेरठ, आगरा, बरेली, झांसी, इलाहाबाद, प्रयागराज, तो ये सारे जो शहर हैं इनमें हर एक में बड़ा मेडिकल कॉलेज होगा ही। उस मेडिकल कॉलेज के आसपास बड़े 2-4 अस्पताल, कोई इकोसिस्टम बन जाता है वहां पे, वही लेबोरेटरी और वहां पे वो डॉक्टर और फार्मेसी। तो ये सिस्टम कहाँ कहाँ आप सोचते हैं एग्जिस्ट करता है, और जहां आपकी प्रेजेंस हो। मेन बात यह है कि जहां आप ऑलरेडी वहां के टीबी प्रोग्राम में पार्टिसिपेट कर रहे हैं उस एरिया के, तो आपके लिए आसान है। स्टेट का जो अधिकारी होगा, एसएमडी होगा, उसके लिए भी आसान रहेगा उसको ऑनबोर्ड करने के लिए, कोई टेंडर नहीं करना पड़ेगा। हमने आपको क्यों बुलाया कि आपको ऑनबोर्ड करने के लिए हो सकता है एसएमडी को टेंडर ना करना पड़े, क्योंकि आप ऑलरेडी एनएचएम के साथ या टीबी प्रोग्राम के साथ इन्वॉल्व हो। तो केवल ये जानकारी हम जानना चाह रहे हैं कि यूपी में आपको लगता है कि डॉक्टर्स फॉर यू कहीं कोई शहरों में इस प्रोग्राम को स्टार्ट कर पाएगा, वो हम जानना चाह रहे हैं। तो अगर आपको थोड़ा समय चाहिए तो हम अगले उसके पास चल सकते हैं।
यस, जैसे आप और बहुत सारे लोग जो पीपीए से चला रहे हैं, उसमें तो यू आर ऑलरेडी इंटरेक्टिंग विद द प्राइवेट डॉक्टर्स। आप उनके साथ काम कर रहे हैं, उनके साथ आपके फील्ड फोर्स का रेपो ऑलरेडी बना हुआ है। उसके साथ ही आप ये काम कर सकते हैं। यू आर नाउ गोइंग टू आस्क देम टू क्रिएट देयर एचएफआर, एचपीआर and then use the ABDM enabled HMISS system. So it can be clubbed with the thing which you are already, or your field force is already doing with the private.
और क्योंकि ऑलरेडी उनका एक डॉक्टर्स के साथ रिलेशनशिप बन चुका है, तो उस रिलेशनशिप को भी आप यूज करके जल्दी कन्विंस कर सकते हो। तो प्लीज अब आई थिंक डॉक्टर्स फॉर यू, अगर आप थोड़ा समय ले लीजिए, सोच लीजिए, लेट अस गो टू द नेक्स्ट वन। हाँ, तो इनसे बात करवाइए।
Dr. Sangeeta Pandey from HLF PPT. She has joined us virtually. Sir.
Hi, good afternoon, sir, and good afternoon all. Yes, actually, PPT is implementing PPH in all the 5 districts that you have mentioned: Maharashtra, UP, Gujarat, Odisha, and Chhattisgarh. Sir, I would like to go forward with this, but I need one meeting to understand all the clarities. More or less, I understand how to go ahead with the ABA creation and to establish ecosystem to maintain the health record linkages with all the labs, chemists, hospitals over there. But processes, I need more clarity on that. Otherwise, one discussion with the team, then I can go ahead with this. I'm okay with this concept.
So Dr. Sangeeta, let me quickly remove this doubt also.
Yes.
As soon as you express your willingness, and your state MD also says कि हम ये इस वाले PPS से ऑर्गेनाइजेशन से काम करवा लेंगे, आपका एक प्रॉपर ओरिएंटेशन एंड कैपेसिटी बिल्डिंग बाय आवर एग्जिस्टिंग टीम, जिन्होंने पाथ वाला बॉम्बे वाला प्रोजेक्ट किया, और जो अभी गुजरात, अहमदाबाद में और सूरत में प्रोजेक्ट कर रहे हैं चाय की टीम, उन टीम्स के साथ बैठ के NHA आपका प्रॉपर ओरिएंटेशन और कैपेसिटी बिल्डिंग जो आपकी एक्चुअल ग्राउंड टीम होगी उसका भी करवाएगा, और आपकी जो मैनेजमेंट या जो लीडरशिप है, अगर उनको भी कोई क्लैरिटी चाहिए
सर,
तो वो भी हम करेंगे। वी आर कमिटेड टू दैट। एक्चुअली हम जानना चाह रहे थे कि आपका प्रेजेंस कहाँ है, आपका कंफर्ट लेवल कहाँ है, किन शहरों में या किन जिलों में है। वी वर जस्ट ट्राइंग टू आइडेंटिफाई दैट। प्लीज गो अहेड, प्लीज गो अहेड।
हाँ सर, इनफैक्ट जो आपने 5 स्टेट लिखा है, और फिर मुझे जो टीम से थोड़ा डिस्कशंस आई नीड टू डिस्कस, क्योंकि मेरे पास ये मेजर सिटीज का नाम नहीं था यहाँ पर। स्टेट वे आर कंफर्टेबल, देन आई कैन आई थिंक कमिट विद द नंबर ऑफ साइट्स, माइक्रो साइट्स। और एक बार आई जस्ट वांटेड टू वन डिस्कशन इंटरनली, देन आई कैन गो अहेड विद दिस. That is my one submission. Otherwise, I am okay. Like in Odisha, we are only in Ganjam. We are not at Sambalpur, Cuttack, and Bhubaneswar, Khordha. We are at Ganjam, Cuttack, and Khordha. So Bhubaneswar MC, that under Khordha we are covering most probably. In Chhattisgarh, we are Bilaspur, Durg, Korba, Raigad. We are there. In Uttar Pradesh, we are at Ayodhya, Gonda, and Rampur. I am perfectly okay, but we need to check with that sites and districts. And in Maharashtra, same, we are bit facing difficulty in Amravati. I will check with this, Nagpur and Pune. So that is the one discussion internally I want with the team, and then I am in a good position to give you any commitment and with the management.
And Dr. Sangeeta, one more, maybe since you have understood this, तो आप हमें ये भी प्लीज फीडबैक दीजिए, क्योंकि अभी हम गाइडलाइंस बनाने जा रहे हैं। क्या जो हम शुरू में मैंने बात कही कि हमारे पास 2 मॉडल हैं, या तो हम आउटकम बेस्ड मॉडल पे जा रहे हैं तो आपको परफॉर्मेंस के बाद ही पेमेंट मिलेगा। दूसरा ये हो सकता है कि हम आपको कुछ हिस्सा उसका शुरुआत में एज अ सीड फंडिंग दें या मोबिलाइजेशन एडवांस दें, तो उसमें आपको पर बैंक गारंटी देना होगा। इस इशू पे भी कुछ आप बोलना चाहेंगे?
सर बिल्कुल, इस पे थोड़ा सा ये है कि कंसिडरिंग कि अगर जैसे बैंक गारंटी के अगेंस्ट में आप सीड फंडिंग देते हैं तो व्हाट वुड बी द परसेंटेज, क्योंकि ये थोड़ा सा
यस,
एक तरह से पैसे फंसाने वाली बात ही हो
जी
जाती
जी
है
जी।
कि
तो
इतने
अभी
पैसे
जैसे
हमारे लग
जैसे
गए
हमने
तो
कहा कि हम 30 लाख का प्रोजेक्ट चला रहे हैं पर माइक्रोसाइट, तो एज ऑफ नाउ वी वर लुकिंग एट गिविंग अराउंड 7 lakhs एज एन एडवांस। एंड अगर मुझे बताया गया है, करेक्ट मी इफ आई एम रॉन्ग, कि शायद 2 से 3%, 3 से 4%, 3% यूपी में बैंक गारंटी लिया गया है। तो अगर 30 लाख का 3% होगा तो पर साइट 90,000 रुपए होगा। तो टेल अस अबाउट दैट कंफर्ट लेवल ऑल्सो, बिकॉज फिर हम उसी के हिसाब से ही बैंक ये हमारी गाइडलाइन बनाएंगे, क्योंकि हम चाहते हैं कि प्रोजेक्ट एग्जीक्यूट हो। ये भी
सर
प्लीज बताइए।
टू बी वेरी ऑनेस्ट, बैंक गारंटी देना इज अ डिफिकल्ट, क्योंकि वी आर इम्प्लीमेंटिंग पीपीएस आल्सो वेयर वी हार्डली गेट वी डू अवॉइड कि बैंक गारंटी, एक तो पैसा तो फंस ही गया वहां पर हमारे, तो बेटर
संगीता जी,
कंसीडरिंग
देखिए
द
ऐसा है,
ऑर्गेनाइजेशन स्ट्रेंथ।
हम मेरी एक ही रिक्वेस्ट है, देखिए सरकार में अगर आप एडवांस लोगे तो बैंक गारंटी के बिना मैं कैसे फाइल पे कुछ लिख पाऊंगा, आप मेरी मजबूरी समझिए। और अगर एडवांस नहीं, बिना एडवांस के चलता है तो फिर बहुत अच्छा है,
तो
मतलब
फिर
वो।
उसके बाद सर कैसे पेमेंट मोडालिटीज पे क्या होगी वो भी समझना पड़ेगा फिर कि
हाँ,
अगर हम
उसमें भी हम आपका इनपुट चाहेंगे। हमारे पास ये जो जितना भी HPR HFR है, बहुत ट्रांसपेरेंटली हमें पता है कहाँ कितना बन रहा है, वो मॉनिटर हो सकता है।
सर
और हम बड़ी रियलिस्टिक एक्सपेक्टेशन है, जैसे हम पहला माइलस्टोन अगर पेमेंट माइलस्टोन रखें कि जी 100 HPR 100 HFR, मतलब 100 लोग डॉक्टर्स का HPR क्रिएट कर दिया, 100 फैसिलिटीज का HFR क्रिएट हो गया, तो 100 डॉक्टर प्लस नर्स, मतलब नर्स भी उसमें बहुत सारे हैं। तो अगर आपने समझ लीजिए 50 क्लिनिक विजिट किए और उनमें डॉक्टर प्लस नर्स प्लस हेल्थ केयर प्रोवाइडर और इस तरह से हैं, तो जल्दी कवर हो सकता है। हाँ, इसमें ये भी है कि डॉक्टर्स में भी ऑल स्कूल ऑफ मेडिसिन, अगर वहाँ कोई आयुर्वेदा वाला बैठा है तो वो भी हमारे लिए तो HPR है। तो ये भी हम अभी गाइडलाइंस बना रहे हैं, मतलब इसमें भी, और गाइडलाइन बड़ा ट्रांसपेरेंट होगा जिसमें देयर विल बी नो इफ्स एंड बट्स। अगर आपने इतने HPR HFR और वो HMIS इंस्टॉल हो गया तो वी आर गुड टू पे, मतलब हम ऐसा नहीं करेंगे कि इसको किसी और तीसरी चीज से लिंक करेंगे।
सर आई कंप्लीटली अंडरस्टूड योर पॉइंट, बट मेरा रिक्वेस्ट फिर भी ये रहेगा कि वाइल कुछ अमाउंट, फॉर एग्जांपल इन गुजरात, आई एम जस्ट कोटिंग बिकॉज आई प्रेजेंस इन गुजरात आल्सो, तो वहां पर दे हैव गिवन जस्ट सीड फंड टू स्टार्ट विद, क्योंकि इनिशियल पीरियड में ही बहुत सारे पैसे लग जाते हैं व्हेन वी आर डूइंग द रिक्रूटमेंट, हायरिंग एंड अदर थिंग्स, एंगेजमेंट, तो सारे एसेट्स सब कुछ देना पड़ता है स्टाफ को। और सिंस वी आर डूइंग विद द अदर गवर्नमेंट फंडिंग, तो अभी काफी प्रॉब्लम हो जाती है विद गेट दैट मनी एंड ऑल दिस थिंग्स। तो अगर इनिशियल एस्टैब्लिशमेंट कॉस्ट कुछ मिल जाता है तो टाइमली रोल आउट करने में सर काफी इजी
तो
हो जाता
हम भी यही चाह रहे थे कि एडवांस हम देने को तैयार हैं, बट उस केस में फिर क्योंकि सरकार के कानून रूल्स ही ऐसे हैं कि उसके बिना, बैंक गारंटी के बिना हमारी फाइल ही नहीं बढ़ पाएगी। तो वो फिर जो भी उस पर रूल रहेगा, तो आई थिंक यू आर सेइंग कि एडवांस का जरूरत रहेगा।
सर रहेगा, बिल्कुल रहेगा,
ठीक,
क्योंकि स्टार्ट रोल आउट करने में इनिशियल में मेजर पैसे लग जाते हैं।
तो आई एम फाइन विद इट,
एवरीथिंग
आई एम फाइन। इनफैक्ट हमें ये फीडबैक आया था कि एडवांस का जरूरत रहेगा, तभी हमने ये बात सबके सामने रखी कि ठीक है एडवांस है तो फिर उसमें बैंक गारंटी का रहेगा। तो आई थिंक उसमें बहुत ज्यादा फ्लेक्सिबिलिटी ना मेरे पास है ना अक्षय के पास है, तो
सर
क्योंकि वो तो GFR के अकॉर्डिंग ही चलेंगे और फाइनेंस उसके ऊपर अपना कॉल लेगा। तो आई थिंक संगीता जी आप एक बार अपना इंटरनल टीम से डिस्कशन कर लीजिए,
श्योर सर, बिल्कुल
एंड मे बी देन यू कैन टेल अस, वी हैव अंडरस्टूड योर कंसर्न्स। तो फिर आप सिटी वाइज हमें बताइए ताकि ये
सर, बिल्कुल सर।
आगे बढ़े। तो लेट अस नाउ हियर वर्ल्ड हेल्थ पार्टनर्स, अखिलेश जी।
Hello, sir. Good afternoon.
जी,
World Health Partners is currently implementing various projects in 9 states of India. In tuberculosis, particularly PPSA, we are in 3 states: Bihar, Odisha, and Punjab, where we are covering 8 districts in Bihar, 2 in Punjab, and 1 in Odisha. And I was listening Dr. Sangeeta and totally agree with her. Of course, the module is quite good and interesting, and we have our presence, so we can think about to start in Bihar. But of course, I have to check. This is my first meeting, and I was not aware about this. So whatever I learned from last 20 minutes, 30 minutes. It looks very interesting and so I will again I also have to check my team, Dr. Neeta, who is not present here today. She looks after the PPSA Patna project, Bihar project. And since Patna, we have been implementing PPIA, then PPSA. I think, of course, we have a good rapport with the doctors, with providers. Patna and Gaya, maybe two cities.
And your take on requirement of a seed fund and mobilization advance kind of a thing?
See, of course, any NGO, if you are looking for NGO cannot work without seed funding.
Done.
Yeah. So that's totally, I agree with Dr. Sangeeta. In fact, in PPSA, I am surprised they don't give any seed funding, and there also we have put bank guarantee. So, which is quite good to listen from you that bank guarantee is needed when we are giving the advance. So, of course, that advance is always needed for organizations like non-profit.
Right. Thank you, Akhilesh. I think let's go to Bhavya Health Services. Suresh Kamble.
Good evening to all of you. This is Suresh Kamble from Bhavya Health Services Private Limited, Vijayawada, Andhra Pradesh. We are operating in 2 states, Andhra Pradesh and Telangana. In Andhra Pradesh, we are covering entire state. Recently, a couple of days back, we got communication from the state government to start operations in 3 districts, erstwhile districts of AP. I mean, like Kurnool, Chittoor, and West Godavari. Now, in AP, we are covering entire state, whereas in Telangana, we are covering only 10 districts.
Okay. This is and TB. In TB, you are covering whole of AP, all the state, and Telangana.
Yes.
Okay.
Telangana 10 districts. That is our presence currently. And in Telangana also, we started 4-5 months back only. From December last year only, we started operations. And based on that, I have a couple of questions to you. Like one is, can you please right now clarify us on number of hospitals which are already integrated with ABDM, their HMS integration with the ABDM currently, and
so let me just share with you. Currently, we have 2 lakh hospitals who are there on the health facilities registry already.
Okay.
And
50,000
as well as 1.5 lakhs doctors HPR on the HPR registry. Now, when you come to how many are using HMIS you have to in terms of number of softwares that have integrated with us, it is 100. But when it is public HMIS like eHealth and eSushrut, you can imagine their wide outreach, because a full state would be using eHealth. So a lot of hospitals which are using HMIS. Vikram, you want to comment?
I just wanted to say that out of 200,000 hospitals registered on HFR, around 50,000 hospitals have an HMIS, have an ABDM enabled HMIS, and about 2,500 hospitals of such hospitals are privately owned. Otherwise, all of them are government.
How many are privately owned?
2,500.
So aisa hai, I think your concern.
Yeah.
Let me put it this way: this project of microsites, we are aiming to increase adoption of the private sector. इसीलिए सरकार पैसा खर्च रही है कि प्राइवेट, हमने अपने वाले जो पब्लिक HMIS हैं, eHealth, eSushrut, eSanjeevani, ये वो सब वो तो हम सरकार की तरफ से कर ही रहे हैं
जी।
हमारी अभी कोशिश है प्राइवेट के लिए। और प्राइवेट में आपका कंसर्न विक्रम ने बताया जैसे कि 50,000 में से केवल 2,500 प्राइवेट है, बाकी सब सरकारी वाले फैसिलिटीज हैं। तो देयर इज लॉट ऑफ सैचुरेशन एंड देयर आर लॉट ऑफ लो लाइंग फ्रूट्स, लो हैंगिंग फ्रूट्स। तो आप जल्दी कर सकते हो, आई मीन इफ दैट वाज योर कंसर्न।
क्योंकि वहां पे जो प्राइवेट हॉस्पिटल्स है, तो HMIS अगर वो लेके आना है हॉस्पिटल में, दे हैव टू इन्वेस्ट ऑन सॉफ्टवेयर।
इसमें भी हम आपको बता दें, आप हमारी वेबसाइट पे जाएंगे, वो प्राइवेट सॉफ्टवेयर जो हमारे साथ इंटीग्रेट हो गए हैं, वो मंथली रेंटल मॉडल पे ऑलरेडी अपनी सर्विसेज दे रहे हैं।
Okay.
और वो लोग भी, जैसे मैंने पहले कहा था, इट इज नॉट ओनली यू हु विल बी पुशिंग दी HMIS, वो
Okay.
प्राइवेट प्लेयर भी फील्ड में उतरेंगे और वो भी अपना प्रोडक्ट सेल करेंगे। एंड ना केवल वो रेंटल पे दे रहे हैं, कुछ प्रोडक्ट है जो फ्री दे रहे हैं, प्राइवेट वाले भी फ्री दे रहे हैं।
Okay. Okay.
तो ऐसा नहीं है कि मतलब इसमें देयर आर डिफरेंट बिजनेस मॉडल। कोई 3 साल के लिए फ्री दे रहा है तो उसके बाद पैसे लेगा, और
Yeah.
कोई हो सकता है आज 200 रुपए महीने पे दे रहा हो।
जी.
These players are already there. Once we'll have these orientation sessions with you.
Sure.
जब आप ये कार्रवाई करेंगे HMIS की, तो बहुत से प्राइवेट प्लेयर भी वहां आपके पास आएंगे और आपसे जुड़ेंगे और वो भी अपनी कार्रवाई करेंगे।
और इसमें से कुछ HMIS तो मोबाइल पे भी चलते हैं, तो
Yes,
ऐसा
yes.
कुछ नहीं है कि
हाँ,
बहुत
ये
ज्यादा
भी है कि
इन्वेस्टमेंट
आई
करना
वाज
हो।
सरप्राइज्ड, ये क्वेश्चन अभी तक नहीं आया कि जो डॉक्टर अभी छोटा क्लिनिक चला रहा है, जरूरी नहीं है कि उसके पास उसको कंप्यूटर खरीदवाना पड़ेगा, जरूरी नहीं है कि लैपटॉप खरीदवाना पड़ेगा। वो मोबाइल सॉल्यूशंस हैं और वो भी अवेलेबल हैं। और तभी मैं कह रहा हूं कि हम आपका ओरिएंटेशन करवाएंगे। जो पाथ वाला बॉम्बे का प्रोजेक्ट है, धारावी में एशिया का सबसे बड़ा स्लम है, मैंने खुद विजिट किया है। 6 फुट बाय 6 फुट के कमरे में बैठा हुआ डॉक्टर मोबाइल से डिजिटल हेल्थ से जुड़ गया है।
Okay.
ही इज नॉट यूजिंग लैपटॉप, ही इज नॉट यूजिंग एनीथिंग, वो मोबाइल का इस्तेमाल कर रहा है और मोबाइल में ही एंट्री कर रहा है डेटा की। ऑफ कोर्स वो मोबाइल में जो सोल्यूशन है वो उसको किसी ने दिया है, हो सकता है फ्री ऑफ कॉस्ट दिया हो सकता है कुछ रुपए महीने पे दिया हो।
Okay.
डिजिटल हेल्थ रिकॉर्ड जनरेट कर रहा है।
Okay. Okay.
या
Fine. See, और एक ये है कि जैसे one microsite means one city, and how many how many hospitals become one microsite?
देखिए ऐसा है, हमने जैसे पाथ का जो हमारा लर्निंग रहा है, जो कन्वर्जन रेट की बात आई थी ना,
हाँ जी.
जब आप 10 लोगों को अप्रोच करोगे तो उनमें से लगभग 25% लोग HMIS तक पहुंचते हैं।
Okay.
राइट। तो इस हिसाब से अगर हम देखेंगे तो आपको अगर जैसे अगर हमारा एक आउटपुट है, समझ लीजिए नंबर ऑफ HPR, एक आउटपुट है नंबर ऑफ HFR। तो अगर आपको 500 HPR करना है तो लगभग 2000 डॉक्टर नर्स और वो उनको अप्रोच करना पड़ेगा।
Okay.
अगर आपने 500 HFR करना है तो 2000, मतलब आप अंदाजा लगा सकते हैं द कन्वर्जन रेट कुड बी बेटर, क्योंकि आप लोग टीबी में ऑलरेडी वहां काम कर रहे हो, आपका लिंक है, क्या पता आपका जल्दी सुने वो लोग, और हमारी ऐसी उम्मीद है कि आपकी बात जल्दी सुनेंगे वो।
Okay.
तो आप ये मान लीजिए इसी प्रकार से हमारा एक आउटपुट क्राइटेरिया होगा नंबर ऑफ हेल्थ रिकॉर्ड लिंक्ड, और वो हम
Okay.
उसको हम बैक एंड पे लाएंगे। मतलब शुरू में तो HPR HFR ही क्राइटेरिया रहेगा पहले पेमेंट का, बाद वाले पेमेंट में क्योंकि अब HMIS एडॉप्शन शुरू हो जाएगा, HMIS एडॉप्शन के बाद हेल्थ रिकॉर्ड लिंकेज होने लगेगा, तो हेल्थ रिकॉर्ड लिंकेज भी एक क्राइटेरिया बनेगा।
Okay.
बट हाँ, तो इसलिए मैं ये बताना चाह रहा हूँ आपको कि अगर आप 1000 HPR बना रहे हो तो आपको 4000 हेल्थ प्रोफेशनल्स, मतलब डॉक्टर नर्स और अलग अलग तरह के, उनको
जी.
अप्रोच करना पड़ेगा।
Right.
इसमें मैंने आपको हिंट दिया था, अगर एक क्लिनिक होगा तो क्लिनिक में कई तरह के हेल्थ केयर प्रोफेशनल काम कर रहे होते हैं, तो
सही.
एक ही क्लिनिक में 5, 7, 10 भी मिल जाते हैं। या प्लीज कुछ और पूछना चाहते हैं?
जी. अभी जैसे तेलंगाना में हमारा प्रेजेंस केवल 10 डिस्ट्रिक्ट्स में है.
जी
अभी 10 माइक्रोसाइट्स, अगर 10 cities, one microsite means one city, right?
जी जी
So maybe it's maybe challenging for us to identify those 10 cities there, because there are some small districts where
Yes.
there are very few or very fewer TUs are there, or very few private facilities are there.
जी जी नहीं बिल्कुल, इसीलिए मैं कह रहा था, जैसे हैदराबाद बड़ा शहर है,
हाँ जी.
you will have to target larger cities where such an ecosystem can exist.
हाँ.
And क्योंकि बहुत ज्यादा वाइड स्प्रेड भी हो गया तो भी आपको प्रॉब्लम होगा ना, तो ये एरिया हैज टू बी अ कंसंट्रेटेड एरिया ऑफ दिस इकोसिस्टम ऑफ कंसंट्रेटेड एरिया ऑफ पॉपुलेशन, जहां पे ये सारी हेल्थ फैसिलिटीज इकट्ठी आके बैठी हों। तो मैं
Okay.
बिल्कुल आपसे सहमत हूं, आई एग्री विद यू दैट out of 10 districts of Telangana, you may find 2 or 3 or 4. Similarly, out of say X districts of Andhra Pradesh, you may find only 4, 5. We are
Yeah.
not asking you, देखिए, we are having 100 microsites across 36 states. उसके हिसाब से तो 36 states and UTs, उसके हिसाब से एक एक स्टेट को 4 4 ही आएगा। But we feel that larger states like UP, जहां population की कमी नहीं है, states like Bihar, larger states like Maharashtra, जहां बड़े-बड़े शहर हैं, आंध्र प्रदेश में भी, I'm sure, and Telangana, Karnataka, bigger cities, पंजाब I know personally, वहां पे 4-5 शहर आज शुरू कर लो. तो ऐसा नहीं है, ये tier 1 cities में ही नहीं रहना है, tier 2 और 3 cities में भी potential बहुत है.
Okay, fine. And coming to this financial thing, and we are okay with the mobilization advance against bank guarantee or without mobilization advance also.
Okay. Right. Thank you.
Thank you. Yeah.
I think let's go to Disha Foundation, Dr. Vishikha or Dr. Shankar.
Yeah, so good afternoon, sir. This is Dr. Shankar here. So from Disha Foundation, I'd like to introduce about Disha. So I'm leading this PPSA project in Disha in Maharashtra, Goa. I also support HLPPT and Alert India in Jharkhand. If we have time, I'd like to quickly introduce the model which we are implementing. Give you an idea whether it will be a very fast integration of PPSA with microsites. So the PPSA model which we are implementing, it's called Nikshay Mitra model. So Nikshay Mitra are the existing staff of private health facilities which we have assigned, or doctor have assigned as a nodal person for TB related work. So those Nikshay Mitra, the nodal person at that private health facility, carry out all the TB work starting from notification, patient education, counseling, all the activities like HIV, diabetes, bank account details collection, giving FDC to the patients, at the end taking outcome from doctor and maintaining records of it. And all these records are being reported by Nikshay Mitra itself in Nikshay, the software which NTP uses. And those Nikshay Mitras are being incentivized by us. So whatever payment milestones we have with NHM, the same payment milestones we have with the Nikshay Mitra. So whatever work he has been done, we have incentivized depending on the milestones he has achieved. And we observed this is a very, very good model, and it's sustainable. The kind of behavior that has changed among private health sector towards NTP or keeping recording, reporting of TB patients. So it's drastically changed in last since we started implementing PPSA. And we see even in public sector, that kind of recording and reporting is not done. The motivation is incentive person. So doctors don't have time for this. So though that nodal person do it very effectively, and it's been very well run. So we have almost 1,000 health facilities which are active and notifying TB cases, and those 1,000 out of those 1,000, almost 800 health facilities doing this, having this Nikshay Mitra and keeping all record and reporting in Nikshay, a mobile app itself. So it will be very, I think it will be very feasible for us, and use that existing mechanism of Nikshay Mitra and push this digital health mission as well. So we can target all those 6 districts of Maharashtra, or even we are going to get 7 more districts in upcoming PPSA for Disha, and even HLPPT is also going to expand. So all those districts, definitely we can take over. All districts, specifically the district headquarters, have a good capacity and presence of private health sector. And it will be quite easy for us to implement. Coming to challenges, what we major face is a major challenge we face is a Nikshay mobile app. So that app which we are using, and even private health facilities are using for reporting, but many times it doesn't work, function well, and then there are repercussions from private health sector. So whatever the HMIs we are trying to deploy or going to use, that should be robust and it should not hamper the progress we have made for engagement with the private health sector. Second, if we are going to use existing HMIs or the private HMIs, I think that will be a good preferred option by private doctors as well. And it we just need to see with what different types of MIS they're using and whether that is feasible to for linkage. Third thing, I'm not very sure what will be the targets of health facility or a health provider registry for each microsite. But if we get the details about all milestone data and the targets for them, that will be helpful for us to budget from our side as well, because you mentioned around 30 lakh for each microsite. We are not very sure how much HR we are going to need, because considering the kind of project, we might need a dedicated HR along with our PPSA staff. So that kind of HR or other logistics. So we need to do a kind of do a brainstorming on the budget requirement, and we can communicate further with you whether it's feasible financially or sustainable for us to implement. Regarding mobilization advance, definitely that will be helpful. We know bank guarantee will be required, but we have already submitted. Our performance security is already with NHM for PPSAs. So maybe if possible, if you can explore whether that can be used.
That won't be possible.
As a kind of checking mechanism.
No.
Otherwise, it's again giving a bank guarantee, the money will get stacked, and it's basically of not that helpful for organizations.
See, you are trying to convince me. I may get convinced, but there are people, who actually sit on the file, finance people, they will never get convinced. So that is how, governments function. And in TB program, I think even without providing any seeding advance, mobilizing advance, they have given bank guarantee. I think we are very fair, offering and discussing a very fair thing with you. So I think let's not put a spanner in the works.
Sure. So somehow we managed to convince MD NHM of Maharashtra to give mobilization advance for upcoming clusters without bank guarantee. So we
can also look at that, because we'll be releasing the money to the SMDs, to the state SMDs. So I think we can leave the flexibility. I mean, that decision will be something which will be taken at the state level. So we can always do that.
Yeah. So they already have some performance security from our side, so that can be mentioned.
Yeah. Our mobilization advance is much more than the BG that could be asked, like 3%.
Even if it is asked, that is where, would be quite meager compared to the mobilization advance which we are ready to give out.
That will be fine, sir.
I am not actually wanting to get into this argument, because हम आपको ये मीटिंग है ही इसलिए ताकि हम आपका व्यू जान पाए. Whatever you are saying, we will note down. Don't worry. है ना? तो हम आगे बढ़ते हैं, because Dr. Vishikha is also here from your organization. आप कुछ कहना चाहती हैं? फटाफट बताइए.
Thank you. Gurgaon.
Okay.
So we are working. We are not working on a PPSA, but we are working with private practitioner as well as government facilities for migrant workers.
Right.
So we work on accessing their healthcare. So we, identify the healthcare providers there, nearby sites, construction sites, or maybe the slum areas, and we do work with them. And same model we do that.
Right.
We have a nodal person in every clinic or every setup, and we do work with them if it is possible for you.
Right, I know we are completely flexible. That is why we want to get your views on this, because finally our priority is that the project should get executed. And for that, whatever you have said, even in Gurgaon, we would be giving that flexibility maybe on a later date.
Okay.
Because we feel that with TB, you guys have an engagement in the states. It will be easier for the SMD to initiate the project. but in places where you are not engaged through TB, but
TB,
having
yes.
your presence because of some other program, we can have a second set of guidelines for that.
Right.
Let me again say, as I highlighted earlier, we don't expect these 100 microsites to start on one day. So even for you, for all of you, you may look at starting with 2 or 3 in one state, and then if you feel that there is something in it for you, it is feasible, it is doable, then you can take a call. We are not asking you to jump with the, all in with the 20 microsites all in. We don't want you to commit that much.
All right.
You can start with maybe 2, 3. You will quickly know that, whether it is workable or not. So please don't think it like, 20 microsites all at once. Yeah, please. Now let us move to Maharashtra Jan Kalyan NGO. Akbarji is here, I think. I'm told.
Good afternoon, sir.
Yeah, good afternoon.
सर अभी जितना भी डिस्कशन हुआ, मुझे थोड़ा इसमें एक ये क्लियर करना था कि जो आप माइक्रोसाइट बोल रहे थे, एक्चुअल में माइक्रोसाइट का वॉल्यूम कितना है? अभी जैसे मुंबई देखा जाए, मुंबई एक डिस्ट्रिक्ट है, लेकिन ट्यूबरक्लोसिस वर्क के लिए इसको अगेन 24 डिस्ट्रिक्ट्स में डिस्ट्रीब्यूट किया गया है।
राइट।
तो ये जो जैसे आप बताए, दादर एक डिस्ट्रिक्ट है, कुलाबा एक डिस्ट्रिक्ट है, मलाड एक डिस्ट्रिक्ट है, तो ये एक डिस्ट्रिक्ट को हम एक माइक्रोसाइट पकड़ेंगे या फिर पूरा मुंबई एक सिटी को पकड़ के हम एक माइक्रोसाइट करेंगे? और इसमें वॉल्यूम कितना रहेगा? जो भी HPR रहेंगे या HFR रहेंगे, उसमें एक साइड के लिए आपके लिए कितना, मतलब 100 रहना चाहिए कि 150 रहना चाहिए? कितने इसमें FPR और HFR होना चाहिए एक साइड के लिए? एक वो मुझे कंफ्यूजन था थोड़ा, वो क्लियर करना।
आई थिंक ये बिल्कुल वैलिड क्वेश्चन है। मुंबई में जो पाथ ने प्रोजेक्ट चलाया 7 वार्ड में चलाया। मुंबई में टोटल 28 वार्ड है, तो 24 तो लगभग 1/3 से थोड़ा कम वार्ड उन्होंने लिया, विच मीन्स 1/3 मुंबई, मतलब अगर मुंबई की पॉपुलेशन 3 करोड़ लगाएं तो 1 करोड़ पॉपुलेशन एरिया और उतने डॉक्टर और वो कवर हुए। दैट इज समथिंग वेरी वैलिड क्वेश्चन कि अगर बड़े शहरों में तो उतना पॉपुलेशन और उतना एरिया इन्वॉल्व होगा, मिल जाएगा, बट इन वेरी स्मॉलर टियर 2, 3 सिटीज वो हमें देखना पड़ेगा। आई थिंक दैट्स अ वेरी वैलिड पॉइंट।
सर हमारे टेंटेटिव गाइडलाइंस में करीब 2000 फैसिलिटीज का एक माइक्रोसाइट, अराउंड 2000 फैसिलिटीज का एक माइक्रोसाइट माना
तो
है।
2000 फैसिलिटीज या 2000 डॉक्टर वाला माइक्रोसाइट बनाएंगे, वो भी हमने सोचा था टियर 2, 3 वाले में। और बड़े शहरों में जो कैपिटल सिटी है या बड़ा शहर है, जैसे मेट्रो ही है, तो उनमें जो है 2000 से ऊपर 4000 तक, 6000 तक भी जा सकता है। जितने ज्यादा आप बनाओगे HPR HFR, उतना जल्दी रिकॉर्ड लिंकेज का टारगेट पूरा हो जाएगा। फाइनल मीट्रिक जो है, एक जो फाइनल पेमेंट का मीट्रिक होगा, वो रिकॉर्ड लिंकेज भी रहेगा। या प्लीज।
ओके सर, तो मैं इसमें मोटा मुझे समझ में ये आया कि हम मुंबई के अगर अभी हम जो इम्प्लीमेंट कर रहे हैं 16 डिस्ट्रिक्ट्स में हम कर रहे हैं, तो अगर 16 डिस्ट्रिक्ट में हम हर डिस्ट्रिक्ट कोई भी इरैंडमली कोई भी डिस्ट्रिक्ट में हम FPR और HFR रजिस्टर कर रहे हैं, अगर वो 2000 या 3000 क्रॉस करते तो हमारा वो एक माइक्रोसाइट कवर हो जाता है। उसके ऊपर जाते तो फिर हमारा दूसरा माइक्रोसाइट एक तरह से हम बोल सकते हैं कि वो स्टार्ट हो जाता है।
मैं फिर कहूंगा कि ऐसा नहीं है कि एक माइक्रोसाइट कवर होकर दूसरा स्टार्ट हो जाएगा। हमारा मतलब ये है, इट इज ज्योग्राफिकली कॉन्टिगुअस एरिया। आप जिसे डिफाइन कर सकते हो कि ये एरिया, जैसे अगर हैदराबाद है तो हैदराबाद का कॉन्टिगुअस एरिया कोई आप ले लिया, उसमें जहाँ अच्छे अस्पताल सरकारी और प्राइवेट और आसपास लेबोरेटरीज और फार्मेसीज एक बड़ा एरिया में लेके वहां आपने इसको अच्छे से HPR HFR बनवाया और वहां HMIS एडॉप्शन करवा दिया, और ये सब होने से आपको पेमेंट शुरू हो जाएगा। उसके बाद आपका जब रिकॉर्ड लिंकेज, अब वहां पे रोज पेशेंट आएंगे उस एरिया में, तो हो सकता है रोज के 10,000 पेशेंट आ रहे हो। 10,000 में से जैसे जैसे रिकॉर्ड लिंकेज शुरू हो जाएगा, तो आपका एक उसके बाद वाला जो एफर्ट है वो इतना नहीं है, शुरू वाला एफर्ट ज्यादा है, जिसके लिए हम आपको शुरुआत में मोबिलाइजेशन एडवांस देने की बात कर रहे हैं।
ओके सर, तो जैसे हम बताएं मुंबई में हम ये 16 डिस्ट्रिक्ट में करें, तो ये 16 डिस्ट्रिक्ट में जो है हम इजीली स्टार्ट कर सकते हैं, क्योंकि बहुत से हेल्थ फैसिलिटीज जो है, बिग हॉस्पिटल है, वहाँ पे हमारा स्टाफ भी अवेलेबल है जो पूरे डेटा वगैरह के निक्षय में डेटा एंट्री वगैरह कर रहे हैं। तो ये बहुत इजीली हम जो है स्टार्ट कर सकते हैं बिग हॉस्पिटल जो हमारे 16 डिस्ट्रिक्ट में। उसके साथ साथ अभी जो न्यू PPSA टेंडर मुंबई महाराष्ट्र में हुआ है, तो उसमें हमको पेरी मुंबई के भी कुछ 3-4 डिस्ट्रिक्ट्स और ऐड होंगे। तो वहाँ पे भी हम ये एक्टिविटी स्टार्ट कर सकते हैं इजीली, वहाँ पे भी बड़े बड़े हॉस्पिटल्स है, तो नियर बाय हॉस्पिटल हम कर सकते हैं।
राइट।
और दूसरा एक क्वेश्चन था सर रिगार्डिंग एडवांस के बारे में, तो मुझे सिर्फ ये था कि जैसे आपने बताया कि अगर बैंक गारंटी जो है 3% है तो उसमें कोई प्रॉब्लम नहीं, क्योंकि 3% अगर देते एक टोटल ओवरऑल बजट का तो 90,000 होता है। तो सिर्फ मुझे एक ये था कि अगर हम एक 3% का आपको बैंक गारंटी दे रहे हैं, तो आप जो एडवांस है वो एडवांस कितना रहेगा, वो टोटल बजट का 10% रहेगा या 50% रहेगा? तो एक्चुअल में वो उससे हम पता चल सकता है कि हमारे पास कितना अमाउंट जो है एडवांस आएगा, ताकि हम बाकी के एक्टिविटी जब तक पेमेंट रिलीज नहीं हो सकती तो हम ये फंड यूटिलाइज कर सकते। तो मुझे एक अंदाजा था कि जैसे आपने
आप
बताया
बताइए
बैंक
कितना
गारंटी के
होना
लिए,
चाहिए, कितना
हाँ,
होना
तो मैं वो पूछा था कि अगर वो 10% या 20% होता है तो फिर हमारे पास एक इनफ अमाउंट रहेगा। अगर 6 लाख तक आता है तो हम उसमें फिर 90,000 जो है बैंक गारंटी इजीली दे सकते हैं।
तो हमने तो 25 बोला था, हम 20 कर देते हैं।
नहीं, मैं सिर्फ इस बात बताया था सर कि 20-25 भी था तो बहुत अच्छी बात है। तो उसमें फिर हम एक 3% जो है बैंक गारंटी वो इजीली दे सकते हैं, फिर उसमें कोई इशू नहीं है।
तो हमें पता चल गया कि 20 से भी चल जाएगा।
ऐसा मत बोलिए सर, बाकी के पार्टनर सब सुन रहे हैं। तो
जी।
एक ये क्लियर हो जाएगा सर। तो फिर अगर 25% बैंक गारंटी मिले तो हम 3% जो है बैंक गारंटी दे सकते हैं, उसमें कोई इशू नहीं है।
चलिए, अभी तो ये डिस्कशन है, इसको हम, इट इज नॉट येट फॉर्मुलेटेड इनटू अ गाइडलाइन, इट इज जस्ट वी वांट टू हैव योर व्यूज, एंड फिर इसके बाद ही गाइडलाइन बनेगा। So we are just gathering your information, all the feedback. Thank you.
Thank you, thank you.
Alert India के Miss Daisy.
Yes, good evening.
Yeah, good evening.
हमने मुंबई में ऑलरेडी एपीडीएम के एक्टिविटीज शुरू किए हैं। मैं ये कहना चाहती हूँ कि हमारा प्रेजेंस गुजरात में भी है। हम पीपीएसए के एक्टिविटीज इम्प्लीमेंट कर रहे थे 4 डिस्ट्रिक्ट्स में। तो 4 डिस्ट्रिक्ट्स में, सो इट्स अहमदाबाद, सूरत, जामनगर एंड कच्छ। तो we would want to extend these activities to these districts in Gujarat.
Right. बट वहां आपका पीपीएस से एंगेजमेंट खत्म हो गया क्या वहां पे?
जी, अभी खत्म हुआ है। बट जो लेटेंट टीबी के एक्टिविटीज है, तो ये लेटेंट टीबी के एक्टिविटीज के कारण हम अभी भी प्राइवेट सेक्टर से लिंक्ड है।
राइट। नो, इसमें केवल ये है डेजी जी, इशू ये है, जो अगर आप पीपीएसए से एंगेज्ड हैं ऑलरेडी, तो एसएमडी जो हमारा स्टेट का ऑफिसर है उसके लिए आसान हो जाएगा आपको एंगेज करना। और अगर आप एंगेज नहीं है एज अ पीपीएसए, तो एसएमडी को हो सकता है वो टेंडर करना पड़े, आरएफपी फ्लोट करना पड़े, तो वो सब है। तो इसलिए केवल पीपीएसए वाली बात है, हमें इसमें कोई हर्ज नहीं है। हम तो एसएमडी पे छोड़ देंगे, वो जैसे भी आपको एंगेज करना चाहता है वो करे।
ऑल राइट।
तो आप गुजरात में कर रहे हैं, मुझे बताया गया है कि शायद जो सूरत अहमदाबाद में आप शायद कर रहे हैं चाय के साथ।
जी, सूरत, अहमदाबाद, कच्छ और जामनगर।
राइट। चलिए।
Okay,
कैन वी
so
मूव
that
टू
is it. That is it.
दिव्य ज्योति सोशल डेवलपमेंट सेंटर, श्री अनिल शर्मा जी।
हेलो।
यस
हेलो, गुड आफ्टरनून सर सौरभ बात कर रहा हूँ मैं, स्टेट लीड पीपीएसए। एक्चुअली सर मैं थोड़ा सा लेट ज्वाइन किया हूँ तो मुझे ऑब्जेक्टिव क्लियर नहीं हुए हैं सर। सर थोड़ा सा छोटा सा एक ब्रीफ कर सकते हैं?
नहीं, हम ऐसा करेंगे, अब हम सबका समय नहीं वेस्ट करेंगे, हम आपको अलग से ही कर देंगे।
ओके, राइट सर।
वेस्ट एवरीबॉडीज टाइम।
ओके, राइट सर, राइट।
यूथ फॉर एक्शन, मिसेस लालरन हेती। Okay, so we have.
Hello, can you hear?
Yes.
Yes. So actually, I've been listening, and since I don't speak Hindi, I don't understand some of your conversations, so I'm really sorry about that.
No, my apology. Because I was trying to speak in Hindi to make, it is very eloquently tell everybody, but I'm sorry that, in a way we have not been able to reach out to you. So, but I think, were you able to understand some part of it, or most of it is not?
Yes, I'm able to understand some part of it, but since this project is a little bit new for us, And even the PPSA project is still only around 3 years. We've only been working on for 3 years only. There are some things we still have to discuss, and if regarding this project, I think it will be possible. Let's hope it is possible to implement in Mizoram. But we will need to get more information so that we can study this project amongst our group.
Right.
So will that
Right.
be
So
possible?
let me share with everybody, and especially you. We are also
Yes.
looking at relaxing the the milestones HPR, HFR for hill states and northeastern states and for islands. So that kind of flexibility we are also looking at. So I think that we do appreciate that the northeast as well as hill states sometimes have smaller cities. The cities are not huge.
Yes.
So we do recognize that.
Yes. Yes, our geographical area right now is only in Aizawl. So we are planning on expanding our PPSA beyond Aizawl throughout Mizoram. But still, the project is still not, we haven't really make big discussions about it. But we already mentioned about expansion. So we hope that, yeah, even through this project also, we will be able to do it. So yeah, if you can share us the PPT or anything, I will give it to my higher ups, to our higher ups, and have a group discussion about it, and then we can get back to you as early as possible.
Right. Thank you, Tarini.
Thank you so much.
Yeah, let's move to Care India. Ramakrishnan ji.
Namaskar, sir.
Namaskar.
Ramakrishnan, team lead for ICT, Information Communication Technology implementation in Care India. Yeah. Actually, we are in Bihar. We are a technical support unit for Bihar. All 38 district we are there. Last 10 plus years, we are supporting system strengthening work. So most of the government related work, not the private side, more on the health system strengthening we are working, sir. इसके अलावा 18 स्टेट्स में है, स्पेशली आंध्र प्रदेश, तेलंगाना, झारखंड and Uttarakhand. Now also we are supporting Char Dham Yatra screening clinics.
Okay.
So during COVID, we got almost 1,000 plus doctors. Pan India, we supported in all states, especially vaccination. We ourselves did 2 crores vaccination.
In fact, you can have a microsite around the Char Dham Yatra also, since you are already implementing it. So you'll have a lot of footfall there.
Haridwar and Rishikesh,
Yeah,
already
so
our screening centers are there.
Screening centers you are generating the health record at each screening center.
Yes, sir.
So you can look at that and
ABBA,
you can create ABBA there.
ABBA ID, assistant ABBA, we can.
Whatever software you are using at the front end, at that help desk, right? So that software, if you can, we can have that integrated, creating ABBA, that health record of the patient can then be linked to it. So that can be a very quick microsite, and it will run for up
Next
to September.
6 months, 6 months will be there, sir. And we have our own application. We are in the M1 state. We have, if it is M1 is released, we don't need to.
So we can quickly do that.
We can showcase.
Good experience. So a lot of footfall is going to be there.
We can showcase. We can start implementing directly from the screening clinics itself, from the ABBA integration, ABBA generation perspective. That's one thing, sir. We are comfortable with the Bihar because of the engagement, long engagement in Bihar.
But you are not a PPSA in Bihar.
Not PPSA.
So how will the SMT engage you? वो कैसे पकड़ेगा आपको कि आप ही करो? That is the decision maybe the SMT can take.
We have support with the MD NHM and other non-financial agreement with a couple of states में है, झारखंड में है, and आंध्र प्रदेश में भी है. हमको देखना होगा, वो प्रोसेस थोड़ा देखना होगा, especially पटना and all, because of large team, 2000 people रहते थे, अभी कम हो गया है. Large team is there in Bihar even now. We are working in Kalazar. A lot of link workers are there, still there. हम लोग कुछ लेवरेज कर सकते हैं, बट बिहार में कहीं भी हम पायलट तौर पे we need to set that 2000 वाला, क्योंकि mostly Patna, beyond Patna you don't find so many private providers from the everyone come to Patna Medical College or Darbhanga, those in and around.
In Bihar I would think that Bhagalpur, Muzaffarpur, Gaya are larger.
If you compare the Patna, वहाँ कुछ नहीं है.
Okay.
और
small clinics तो होंगे.
वो all are.
No.
I don't know.
Patna is a
RMPs
bigger city, but you have like a lot of private providers you will get in Bhagalpur,
Yeah.
Gaya.
Actually.
These are very big cities.
Yeah, in fact,
Muzaffarpur.
somebody gave me the feedback
Yeah.
that in UP and Bihar, you know, the population is so huge that you have these small clinics.
That
small
only is
doctors.
sustaining actually.
Sorry?
That only taking care of all the
Bihar-
non-maternal thing. Maternal people are coming here.
Other cities other than Patna, Bhagalpur, Muzaffarpur, Gaya, and
yeah.
lot of those. I think they are good for, because smaller clinics, good number of HFR, good number of HPR. So I was given this feedback, but I think you are giving a totally different feedback that people, it is easier in Patna.
Patna is a concentrated. You were saying concentrated is Patna, because everybody come to Patna. If you look at the like, you can convert into clinics, polyclinic, and 10-bed hospital, 30-bedded hospital, 100 plus.
Right.
So 30 and 100 is more on Patna, I think. Lesser is there.
Yes,
clinics.
Small clinics is important because that is where this private uptake will. But anyway,
so
even
Bihar somewhere we can because of the engagement with the government, Bihar we can look at some of the microsite, and Andhra Pradesh, Telangana also we have the people there, especially Visakhapatnam, Vijayawada, Guntur is a focused. You have a lot of healthcare providers in Vijayawada. Suryapet Road, it is called. It's thousands of practitioners, hospitals will be there. We can look at it, and we may leverage the medical representatives to reach out these guys. That some of the strategies we can bring. So I think इसमें तीसरा वाला milestone ही बहुत मुश्किल है, because of the that HMS, their fear of IT raids. उनको केस नहीं दिखाएंगे, ये सब myth है उनका. So वो एक point को हम कैसे break karna hai, that has to be look into it. So HFR and HPR is fine. So that's why even your 25% people are not converting into digital because of their fear factor. Like 150 patients they are looking at. So they don't want to expose it.
Which means Dharavi is successful because their people don't fear IT because they don't have anything to fear from IT. That is your thing.
I don't know, sir, but in Vijayawada, we were trying. I was trying last.
You are right.
20 years I am into healthcare IT, and
let me also share with you my this the profound impact that it had on me. We were in Dharavi. The poor people and the single doctor clinic was quickly shifting to this and adopting it. The larger clinics were still giving me this logic. Why should we shift? We have spent so much. Why should I make it available to IT people? Police will come, this, that. So the learning here, which I had, is the person who has nothing to lose and who just wants to save time. He's the one who is ready to make the quick switch to ABDM. So you are right. But this thing will come. That is why we need the foot on ground. That is why you are needed. Otherwise, had everything been happening very quickly and
like government engagement happen, all the professionals, almost 80-90% we have reached.
So similar, let me give you another feedback. जो MBBS डॉक्टर हैं वो सबसे ज्यादा ज्ञान देते हैं हमें, नहीं हो पाएगा. जो आयुर्वेदा वाला है,
आयुर्वेदा इजी,
वो बोलता है हमें दो सर, हमें सर्टिफिकेट दे दो, हम HPR पे आ जाएंगे.
इनके
so आयुर्वेदा, this Indian system of medicines, nurses, they are ready to shift to ABDM, but the medical doctor who is who says I have done so much, वो नहीं shift करेगा. But let me also give you another insight. I think these were, maybe we could have in the capacity building thing. It is not the doctor you have to talk to, it is the receptionist. Every doctor has a person at the reception or the person who sits outside and who maintains the record. When we were interacting with doctors who had adopted it and we asked them, would you now go back to the old system? He says, if I go back to the old system, I will lose my receptionist. वो छोड़ के चला जाएगा. Because he has become used to digital way. So that is why when I think Akhilesh ji was telling, when I said ki absolutely, when he was saying ki we have developed a mechanism of incentivizing these mitras, TB mitra, Nikshay mitra. So that is the model. If you capture, doctor is dependent on his receptionist.
Yeah, even in even in Bihar, we use compounder, and we have in PPSA we have incentives for them. They are the one who notify, who inform us, and because doctor have no time.
Yes. So I absolutely agree with Akhilesh, and that was a learning for me also. Doctor ko nahi pakadna hai. You don't have to capture the doctor. You have to capture the receptionist or the compounder or whatever support staff he is using. Usko pakad liya to doctor is caught. Then this whole logic of IT raid XYZ will go. Sorry.
Yeah.
Anybody wants?
So that's what, if it is the RMP thing, I don't know what kind of guideline we need to look at. RMP is a large in quacks, especially.
No, see, and as far as we are concerned, our healthcare professional definition is clear.
Clear.
We can't include a self-proclaimed person who says I am faith healer or anybody. So we have to draw a line somewhere.
So that is not there, no, outside of.
How can that be there?
Yeah.
All right. So yeah, let's now move to Neurosynaptic Foundation. Samir is here.
I also have Tushar with me.
Yeah.
So first of all, thank you for inviting us to the meeting. We are not Neurosynaptic Foundation, but Neurosynaptic Communications Private Limited.
Okay.
And I'm also fortunate to have worked with a few providers here. Secondly, we are also not just the digital health equipment manufacturer, but provide an end-to-end, I would say, continuum of digital health, starting with the digital health indigenous devices manufacturing to a platform which is now also in the process of getting registered with ABDM.
Just excuse me for 5 minutes. Akshay will continue. Yeah.
And also providing services at the last mile for the digital health at many of the PHCs through various CSR programs. So this basically with the Remedy set of equipment and the Remedy platform that we have developed. This set of devices are also incidentally integrated with eSanjeevani very recently. So with that background, we are in about 12 different districts in various states at this point of time, directly or indirectly with partners. In the 4 districts, Hardoi in UP or Shivpur in Madhya Pradesh, and one more place. We have presence in places like Tamil Nadu, Ramanathapuram, or Shahada in Nandurbar, Maharashtra, for various of the programs, as well as in other places like Balrampur, Varanasi, and Chandauli in UP through partners, or Gaya in Bihar through partners again, and in Karnataka, Tumkur and Gadag, and Mewat in Haryana, and also near Pune in some place, and Virudnagar in Tamil Nadu through partners. So all of these programs basically mean that we have either the personnel or the partners personnel running the telemedicine or digital health solutions already in these places. So I think we work either in the CSR projects with non-financial MOUs with the district health societies, primarily funded by CSR, or with the private hospitals and clinics, or for implementing their centers in these regions for digital health and telemedicine. So this is briefly our setup. We would be very happy to take up the microsites if it is possible for players like us to be involved in this, or even provide our platform for for the private providers who would want to implement that. And I think advance is required for mobilization. We have not really had commercial agreement with any of the health authorities till now. But I think bank guarantee kind of percentage that was mentioned should be fine with us for the mobilization advance. So that's briefly.
Currently, what kind of engagement that you have with the private providers as a communication company?
No, it's not. Communications is again a little,
for the devices you have engagement?
The devices, the telemedicine platform as a provider for teleconsultations in many cases, or for their own centers in many cases.
Okay.
So the hospitals starting up telemedicine centers for outreach, like Meenakshi Mission Hospital in Madurai has 16 of their telemedicine centers which work with our technology and the continuous involvement there. So that is the kind of engagement.
So that solution is provided.
Yes. Similarly, in Pune, we have tie-up with multiple hospitals who have their own centers running on our platform.
Okay.
We have hospitals like Nanavati Hospital, etc., who provide teleconsultations to the sites where we have engaged, like in Jalgaon in Maharashtra or Sindhudurg in Maharashtra.
So do you engage with the doctors who are providing the teleconsultations also?
Yes.
The endpoints of the
yes,
doctors.
we provide the umbrella implementation, which means everything
Because
right
that
from
is
the
going to
medicines.
help you to implement the microsite. Right?
Yes, absolutely. So we have staff on the ground, we have coordinators on the ground, and the nurses at these centers who are deployed by us, and an entire end-to-end operations like medicine procurement, delivery, or the manning of the centers, or the doctors providing consultations at these centers also. All of this end-to-end.
Because this microsite would be more directed towards the single doctor, dual doctor, small clinics.
Correct.
Not the Nanavatis.
So we see this initiative as something supporting to our activity.
Yeah.
We have on one side hospital linkages, and on another side the staffs at the PHC or ground level.
Okay.
And we also create awareness activities and camps as a part of these programs throughout the region where we are operating.
So in your case, we need to explore that how states are going to engage you, because still
Yes,
you
that's-
have non-financial engagement with the state authorities yet.
Correct. That's the one thing that's like.
Let us explore that also.
Sure.
Thank
Hello,
you.
sir, everyone. Hello, everyone. Just hello, Samir ji. Nice
Hello,
to hear
Samir.
you.
How are you?
After a long time, we have been working very closely with Indosynaptic, and we have done almost 300,000 teleconsultations in Bihar and UP.
Yes.
So, and I fully agree with what Samir is saying, that his solution is very close to this your concept. And
Thank
so,
you.
however, the Neurosynaptic is not directly into engagement, but they can be a very good resource.
Okay,
Absolutely.
understood.
And
Thank
since
you.
you are in the developing still in the development of the guideline, I can say that you can think about that.
Yes.
Thanks, Akhilesh.
Thank you. So now may I call upon Dr. Pooja is here from Dr. Pooja is here from Khushi Baby.
Yes, sir. Hema sir will present. Yeah.
We are basically the nodal technical partners to Department of Health, Government of Rajasthan. And our platform is basically being scaled across the state. And we are primarily working on the government side with the community health workers basically using our platform. Basically individual applications for ASHA NM and the medical officer, which are interlinked. This is a project which is something new for us. And frankly, we need to see our role fitment into this case. We do have experience of managing Janta clinics in Jaipur, which is something like Mohalla clinics, whom we are like managing for end to end. But this is something new because we have never worked with the health facility side on the private sector, if I would say. So we can certainly have an internal discussion, and we can actually look for maybe going ahead in Udaipur, which is like a laboratory where we started our work from. But again, it's a policy issue for us, so we need to take a call.
Do come back to us.
Sure.
If you have any kind of doubt or clarification you need for the project, do come back to us, or me, or Shobit, or Vikram.
Sure.
Sir. Thank you so much. Then I may call upon Mr. Anvesh T from Pirwan.
Hello, sir. I'm Anvesh from Piramal Swasthya. I'm joined by Ishmit over call. So from Piramal Foundation side, actually, we are keen to kind of onboard, I mean, kind of start these projects on microsites, especially from Bihar and Assam, which had been very strong operational states for us, actually. So in Bihar, we are working very closely with the health department there on the entire digitization of actually the healthcare system there right now. So this project with the Gates Foundation, the state transformation project, is going on there, and this provides us on ground machinery. Actually, we have Gandhi Fellows and other team members who are stationed at all the districts. And in Muzaffarpur, we had a pilot project which we implemented, which is integrated with the command and control center in Secretariat there. So with that kind of experience, we hope to actually start some project in Muzaffarpur, or we can start with that as a pilot probably, and then take it up to the guidelines which clearly were mentioned, that not clear, but which probably would evolve, that 2000 facilities are the doctors that we are looking at. And also in this context, actually, we visited Path Microsite also in Mumbai, Mahim and Dharavi, both the places. Where it was clear that actually each ward of 5 to 9 lakh population, and with about 10 wards, they actually said that they scaled it up to 10 wards right now. And what we gathered from there is actually each ward has a field coordinator working with about close to 300 doctors. And with all the background, and they have been actually on the ground with the private doctors and facilities from last 8 years in Project Jeet and again PPAS. So with this kind of background, they actually could convert about 30% of the doctors to HPR and HFR. Actually, this is what we learned from them. Yeah, and it was very good to know, and how actually the few of the doctors, and there were apprehensions like Dr. Ramakrishnan was saying, actually, whether the private doctors are willing to kind of adopt the HMIS. Largely what we have seen is that Bajaj Health was the for being free, actually. For being free, they actually started adopting it, but not that many doctors started creating EHRs. It is not happening so very proactively. One of the doctors who generated 1,000 EHRs till now, of the 12,000 EHRs of Path, they said, actually, we are happy to do away with the paperwork that we have done so far. Otherwise, I had to stash large chunks of paper every 3 months. Now, at least because we are able to take the photos and we are able to keep it on the mobile system. But the doctor is not willing to give a prescription on the app directly. It is only that they're taking a photo and actually keeping a digital copy of it. So doctors are also kind of still getting used to it.
Difficult thing to change their behavior. It's
Right.
very, very difficult.
Right. So this kind of learnings kind of actually helped us now to look at what would be, I mean, these were the questions that I also had. What would be the size that we are looking at when we define microsite? If it would be like if we say Darang in Assam, though being district, we have very less number of doctors stationed there. So it doesn't actually make much sense to deploy a lot of resources there. Rather, this definition of actually 2,000 health facilities are probably something like that would help us. And one clarification, sir, if with regard to the DHIS, will there be a linkage to this also? I mean,
Yes, yes.
Okay.
So DHIS would be paying to the people who are generating the data health records and who are doing that,
Right.
and the solution companies who are making the generation of the data health record possible. And this remuneration for the microsite would be different, would be
Right.
completely separate from the DHIS.
And just to add one more point, actually, we have an in-house platform which we deployed in Bihar earlier. Amrit was a platform which is a kind of suite of applications. Like for now, Bhavya is there in Bihar for the front end, actually, the patient registration and the doctor, the HMIS. Earlier, Amrit was there before the MSP was onboarded. And we are actually willing to we have this vision of actually making Amrit platform as a SaaS in the coming 6 to 8 months and make it open source and a digital public good for everyone, so that the private sector also easily onboards actually to a lot of these things, not because of the price complications that they see outside. So this is our vision for actually as far as HMIS is also concerned. And with private sector, till that point, actually, we will probably explore with other HMIS which are out there. But Bihar and Assam, definitely. If possible, Chhattisgarh, Jharkhand, and Odisha.
Okay.
These are the 5 states that we would be looking at.
Thank you.
Just to add, just to add a couple of points. I think Bihar is a great example because we have been able to, we've been actually supporting, like the care representative said, they are the technical support partners in Bihar and we are the digital partners there. And I think in Bihar, our ABDM journey, we have actually supported the state and we are still supporting them for the entire Aadhaar ID and ABDM, and of course, working with the current service provider as it scales up in the public sector to be able to link the EHRs. So I think Bihar, we have presence across all states. That's one example where we can certainly do it. The issue which you have mentioned already is that, since we do not have a PPSA arrangement with the state, we have a PPP arrangement for our 104 operations in many states, including Bihar, Assam, Jharkhand, Himachal Pradesh, Chhattisgarh. So we'll try and explore with the MD NHM there if that can be a way to arrange the payment. But otherwise, that challenge will be remaining with us because but in an example for the TB system, we are trying to do an ABDM demonstration in the Darang district, which Anvesh was mentioning. You are using not only Amrit as one of the clinical management systems, we are also exploring partnership with other private players or public players who are available for technically the private sector as we go to. So I think as far as the project is concerned, we are completely into it. We've been supporting many states in their ABDM foundation building blocks. So that won't be a challenge. The only challenge we'll have to see that how does the payment system work especially if we don't have a PPSA arrangement. That is something which we'll have to work out with each state. And my only sort of request from your side will be that as and when you decide which states and if you're going to give us a go ahead, a clear communication to the MD NHM of that state will help, doing the approvals faster and getting the work started. Because in Bihar, Assam, we can start the work tomorrow.
Understood. So one tangential thought that we in Ayushman Bharat Digital Mission have the state mission director Ayushman Bharat Digital Mission. It's not exactly same as MD-NHM.
SHA
body different. Yeah. It's not SHA also. State health policy is for Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. So in many of the states they are same. The person is the same, but they are separate offices.
So in Bihar and Assam, we are working very closely with the ABDM office there. And because we are supporting them in the blocks. We have an ABDM PMU also there currently working in Bihar and Assam.
May I now like to call upon Ms. Komal from Access?
So like with all these sites, we have a presence in Telangana, but along with that, we are also part of the implementation research, which we are doing. So it was more to get insights on how we are doing with the microsites so that we can align the implementation research, which is before, middle and the later, how we are doing and what are the aspects we are looking at.
Absolutely.
Second thing is so we want to be embedded with the teams from the beginning rather than because every state has a different culture, different preference and different adoption methodology that will work. Not one scale is not going to fit everything. That's what we are seeing working with PwC, PARC and CHAI, that there's difference required and what is the driving force we are still trying to get. That's one objective. Second thing is that as Access Health and as implementation research, we also want to explore the possibility of getting into microsites. Maybe one, may not be one, because that will be a controlled environment where we want to explore. So there's a separate team which has a large presence in Telangana, and we are working with Telangana government and provided them a couple of supports on their tendering, digital and trending process. The point is like still in a discussion phase. So I'll come back to you with more details. And also on the states, where do you want, we can discuss that. We have like in Odisha, you also, but we'll discuss because a lot of things are taken. So I don't know where we want to fit in.
Thank you.
Thank you, sir.
So, Mr. Qasim Sayyed from TB Alert India, I think you have joined us virtually. Are you available on the call, Mr. Qasim Sayyed? Mr. Sandeep or Dr. Akash from Deepak Foundation, are you here?
Yeah. Good afternoon, everyone. Dr. Sandeep Suri from Deepak Foundation.
Please go on, sir. You are loud.
Yeah. So right now we are working in 22 districts of Madhya Pradesh in 3 divisions of Madhya Pradesh. Also, we are having presence in 3 districts of Jharkhand and 5 to 6 districts of Gujarat, like Baroda, Narmada, Chota Udaipur, Bharuch, and Surat. Also, we are having presence in Maharashtra, also in Pune, Palghar, Roha districts. So we are capable enough to roll out this type of projects or microsites in these locations. Yes.
Okay, thank you. Do you have anything to add on financial model or implementation model?
No, sir. All the things have been discussed right now.
Okay. So I think we are far ahead of our time. We are very late now. So any of the participants who wants to add anything or give any input in this while we are still or making up the guidelines, please let us know. Or anyone?
So I just wanted to confirm one more thing. So Doctors for You, as I told, no, sorry, I didn't mention before. So for TB project especially, Doctors for You is working in 4 states and 42 districts. So mostly more districts we covered in Bihar and UP and Assam. And obviously Maharashtra as well, but mostly we covered in these states. So obviously we are willing to do this. So HPR and HFR is we can do more at more areas, like we can do in Karnataka as well. We don't have PPSA there, but still we can do it because we have good connection nearby there. Bangalore Medical Hospital, there are many hospital are connected to that medical college. So yes, we can also do in Bangalore as well. Apart from Karnataka, we can do in Delhi. Noida is obviously it's come under the UP, so we can do it.
So I think additional CEO sir is caught up into another meeting. If you allow, we can, sir. Sir, we have just heard from all the participants and we have noted down their comments. And we heard from almost everybody now. So, sir, upon you, sir, we can conclude all this.
So, first of all, I apologize. I was not here during the latter half of the meeting, and I could not hear your comments. But my team has noted them down. I think largely what we have gathered is that you have your own strengths in particular geographies, which we would like to leverage for our benefit and for the benefit of implementation of ABDM. We have also recognized that since, as has been echoed in the room, that the NGOs would like to have some part of some kind of a mobilization advance. I think that is also noted. I think I hope that point was discussed regarding monitoring and having a organization to support you. That was discussed.
Was discussed. It was also mentioned in the slide also, and it was
Right.
discussed by various of the participants that
Right.
whether they want a level 1, level 2, or that monitoring partner with them or not.
Right. So that is my approach to that would be we will like to keep it flexible for those implementing agencies who feel that they can also take care of the monitoring, development of a dashboard for the SMD. I think the call will be left to the SMD, the state mission director. He may decide that okay, with the particular interface agency, if he doesn't need a partner for monitoring and dashboarding and all those activities, I am happy to not have a partner there. But yes, maybe at some places the SMD may feel that, okay, he's comfortable in having one implementation interface agency, and at the other level also have a partner who helps and guides him through monitoring of the outcomes, and also guides him through the dashboards, development of all these things. So, and capacity building, of course. So I think we can leave this decision to the SMD. In the guidelines, we can be flexible. So today's meeting is largely to, also gauge your feedback, also get your feedback and see what kind of guidelines we should come out with. Because I really didn't want that, these guidelines become a roadblock in implementation. So with your feedback, I think we'll be able to arrive at guidelines which are flexible and which allow this to be implemented. So that was the whole approach why we wanted to listen to you and also know your strengths. For those who haven't given us their mind regarding, their presence, and maybe you need time to digest the information that you have got. So we would request that my team, Akshay and Vikram, they are here and they will interact with you. Please do give your feedback on a later date, and we will still have maybe 1 or 2 rounds with other stakeholders also before we actually get down to finalizing any kind of guidelines. Yeah, thank you for
one
please.
submission, sir. Actually, if you cap the number, that is a good idea, sir, rather than city, geography, because if you change the geography, numbers will change. He was also iterating some places it's very small. So 2000, if you put the cap at the policy level, within that budget, whatever you are doing, that will be.
I think that was also a good takeaway from the meeting.
Yes, sir.
We would have to be realistic with our expectation, because geographies and cities, we will
Varies,
So what we'll do is I think that's a takeaway from the meeting. That is noted. That point is noted. Thank you all.
Thank you, sir.
Thank you, everyone.
Thank you, sir.